Good evening, everybody, and thank you for attending this talk on advanced clinical case studies to improve the burden of COPD. My name is Nick Hill, and you can see my credentials there. I'm a pulmonary physician in Boston at Tufts Medical Center, and you can also see my disclosures for this talk. And I am honored to share the talk this evening with my good friend Bob Schills, who is Director of Pulmonary Vascular Disease and Lung Transplantation at University Hospitals in Cleveland. And you can see his disclosures as well. And our learning objectives tonight are to describe the patient experience of living with and managing COPD, recognizing the health and economic impact of COPD, diagnosing patients with COPD according to guideline recommendations, and formulate evidence-based, personalized, effective, stepwise treatment plans according to guidelines. And we will start out by talking about the global burden of COPD and a little bit about pathophysiology. The current definition of COPD is that it is a common, preventable, and treatable disease characterized by persistent respiratory symptoms and airflow limitation caused by airway and/or alveolar abnormalities, usually due to significant exposure to noxious particles or gases such as cigarettes, influenced by host factors including abnormal lung development. That is according to the most recent GOLD report. GOLD being, of course, Global Initiative on Obstructive Lung Diseases. A brief synopsis of the etiology, pathobiology, and pathophysiology of COPD is represented here schematically. So COPD starts quite early in the face of generally environmental pollutants, smoking being the number one, but indoor air pollution, outdoor air pollution, and certain occupations are also significant factors. And there are also host factors such as the size of your lungs, and also there are genetic predispositions that have been identified, especially matrix metalloproteinases and a number of others. The host factors and pollutants combine to cause lung injury and generate lung and systemic inflammation, which leads to changes in the lung, impaired lung growth if it happens at an early age, accelerated decline in lung function in susceptible individuals. There are the early involvement of small airway disorders or abnormalities, development and acceleration of emphysema, and also systemic effects, which contributes to a lot of the comorbidities. Also, as the disease progresses, there is persistent and increasing airflow limitation that leads to clinical manifestations, including dyspnea, especially on exertion, chronic cough. Exacerbations, of course, are major problems that contribute to morbidity as well as the costs. And then there are quite a number of comorbidities that we will go over in relation to our case. So the burden of COPD is enormous worldwide. It is a leading cause of morbidity and mortality, the fourth leading cause of death in the US. The economic and social burden is substantial and increasing. Prevalence, morbidity, mortality vary by country and by groups within countries, largely related to exposures and the predispositions. The prevalence is predicted to increase due to continued exposure of COPD risk factors. We have made gains with elimination of smoking in certain countries, like most of the US, and the UK isn't far behind, but in many other countries around the world, smoking is still very prevalent, especially in middle and low income countries where the tobacco companies have been successful in getting people to increase the amount of smoking. This is a world map. I kind of like the color scheme, but what it demonstrates is that there are certain hotspots around the world, including the U.S., which is seeing somewhat decreasing in certain populations incidence of COPD if smoking has gone to low levels. But you can see in red there, Nepal, North Korea. I'm sure Kim Il-jung is quite generous with cigarettes with his population. And the U.S., Kentucky, in the red, deep red there toward the northeast, is the state in the country with the highest smoking rates and thus the highest prevalence of COPD. And even though Africa and South America look great, it's more that it's underreporting of COPD than a low prevalence. And this is true in many areas of the world.
Nick, that's a great introduction, and I think it's time to go on to a case. There's one, parenthetically, you mentioned just how devastating early smoking can be, to people. And as, in the transplant world, I don't think I see any people with more devastating smoking-related lung injury that, those that answer back of saying, I started smoking when I was 10 or 11 or something like that. And that's really, and in the context of teen smoking, which has had some blips lately, that's a truly concerning trend. But in that regard, let's then turn to a case, because after all, that's what we do for a living. So let's look at a newly diagnosed stable COPD patient and review the relative or the relevant issues surrounding diagnosis, going through and starting out with a medical history. So certainly the elements of medical history, include, and if this person was a 63-year-old with gradually increasing dyspnea. They wrote it off to old age, but in the review, started smoking early as a teenager until about 3 years ago. So 60 minus 13 is 47 years, and she's about 1.5 packs per day. So that's a lot. Let's put it that way. So extensive smoking exposure from an early age. She mentions that her breathing is fine, quote unquote, when sitting at rest, but most activities make her short of breath. And these can include walking at a normal pace, even on level ground, having to stop after as little as 100 meters, any inclines, stairs, or so forth. She has to pace herself, and dressing and bathing represent challenges. And so this, in general, can certainly represent substantial airflow obstruction. Like so many, she obtained a friend's inhaler or Primatene from the pharmacy, and that helped a little. In addition, there is a cough productive of yellowish sputum, up to a tablespoon or two a day, which she has had for many years. And all of you will then recognize this as as far exceeding the minimal definition of chronic bronchitis. And so if we go a little bit further into her history, we see over the past year, she's had 2 episodes of acutely worsening cough and dyspnea. First one was treated with steroids and an antibiotic, which she obtained from an urgent care center. And the second actually resulted in hospitalization, and she was then referred for evaluation. She has poor sleep, and her children tell her that she snores. She does not feel rested and has daytime somnolence, especially watching television at night. She's gained weight since quitting smoking and accounting for some 30 pounds, and has a history of systemic hypertension and type 2 diabetes. This sounds like a very typical inhabitant of the United States. So if we go a little bit further, and again, this history, as we'll flesh out a little later, not only describes her exposure history, but also fleshes out the presence of expected comorbidities, which, as we'll see, are very relevant to the care and treatment of these patients. So she's divorced, lives alone. has a pet dog. The dog doesn't smoke. She worked for an electronics manufacturer for many years, including soldering, and filed for early retirement because of the effort it took to get around at work. Grandmother and mother had emphysema, and they were both heavy smokers and used oxygen toward the end of their lives. So, this really represents sort of a baseline history, parsing the possibility of comorbidities, smoking history, ancillary exposures, the possibility of family relationship and factors and so forth that Dr. Hill nicely outlined in our introduction. So, Nick, would you like to continue then going over some of the diagnostic challenges then and guide us through diagnosis?
I certainly would. So one of the issues about diagnosis of COPD is that worldwide it is more often undiagnosed than diagnosed, as you can see from the, I guess these are the teal color is for undiagnosed, and the green is diagnosed, but you can see in virtually every country there is more undiagnosed than diagnosed. And another take home from this slide is that the occurrence, the prevalence of COPD varies enormously between countries. As far as the progression of COPD over time is concerned, this illustrates 4 different pathways that patients can take. In the first pathway, you have a patient who has normal lungs and has been a non-smoker, and they have the normal trajectory, which is that our lung function peaks at about age 30, and then it's downhill for the rest of our lives. But it follows a downhill trajectory that leaves us well above remnant lung function that would cause any kind of symptoms. In the yellow, the so-called TR2, this is patients who start out with small lungs, and so at age 25, 30, their lung function is not as high as the normal, but because their lungs decline at about the same rate as the normals, they also do not get into trouble, and they don't have COPD. On the other hand, you have some patients who start out normal. Their peak function is equivalent to somebody who is normal, but then their rate of decline, in red there, is much more accelerated than someone who has normal lungs, and this represents a chronic smoker. And also, if you start out with small lungs, you're at higher risk of ending up with airway obstruction. And so both those end up with COPD. Now, COPD is also overdiagnosed in some cases where patients end up with COPD on their listed diagnoses, and especially with these days of EMRs, it's almost impossible to get rid of it, even if they don't have any evidence for it. Spirometry is central in establishing the diagnosis of COPD, but symptoms are also important, especially increasing dyspnea on exertion, cough, and sputum production. And in the GOLD guidelines, patients sometimes, in stage 1, that refers to patients whose FEV1s are over 80%, and in patients who have cough and sputum, even if their FEV1 is that high, you can make the diagnosis of stage 1 diagnosis. And then risk factors also are important. History of smoking and occupation, as we've talked about. And the kinds of pathways from clinically, the dyspnea is progressive over the time, persistent, and worse with exercise. Chronic cough, maybe intermittent. The patient we got today, hers is fairly persistent and productive. They have recurrent lower respiratory tract infections. They're more susceptible when they get upper respiratory infections to spread to the lower airways. And they have that history of risk factors we've talked about. And they often have a family history, such as our patient did. The patient's mother and grandmother had severe COPD. And as I mentioned, there are genes, genetic abnormalities that have been associated. This illustrates what we expect to see in the spirogram in somebody who is normal versus obstructive disease, but patients will have a delay in exhalation, and you can see that the slope of the increase in volume is shallower than in a normal individual, and the amount they get out in the first second, the FEV1 is substantially less, and as a proportion of the FVC also drops below 0.7, which is considered by guidelines, both GOLD and ATS, to be the cutoff for COPD. In this patient example, the ratio is 0.56, which would be consistent with moderate obstruction. And this is the GOLD staging for FEV1. As I mentioned, 80% or above would be considered mild when combined with symptoms and compatible history and so forth. Moderate, 50% to 80%, severe, 50%, and then very severe, less than 30%. The physical examination is very important in the diagnosis, and the assessments that were done, she's a pleasant, heavy-set woman, and we see a lot of patients now who are obese, and that contributes somewhat to the symptoms. If you're heavy and you're dealing with the same amount of lung dysfunction as someone who's considerably lighter, you tend to get more dyspneic with exertion or with less exertion. This woman's vital signs were remarkable for a slightly high blood pressure. She does have a history of hypertension. Respiratory rate, some might say that's a little bit rapid. O2 sat 91% on room air is clearly not normal and is probably related to maybe secretions and also obesity with some low changing of her closing volume. Her BMI is 38, so she is quite obese. She's pleasant, ruddy-faced, short neck, Mallampati score 4, and she's mildly using her accessory muscles. Her risk for OSA, based on this physical exam, is quite high, along with her obesity and hypertension. She has scattered rhonchi. She's got this productive cough, so chronic secretions, and an obvious delayed forced expiration. Distant heart sounds, probably related to her obesity, and the rest of her exam just notable for no clubbing and some edema. Her CT scan shows central lobular emphysema and coronary calcification. And here it is. It also shows a lot of adipose tissue consistent with her BMI. And you can see the coronary calcifications there. And this is a common comorbidity with COPD, coronary artery disease. She doesn't have typical symptoms of angina. So she has not had an intervention for that, but it certainly would be something one would want to keep in mind. And then here is a discussion question. Which of the following would be most appropriate to use in clinical practice to understand this patient's symptoms and their impact on her health-related quality of life? The evaluating respiratory symptoms in COPD, the Leicester Cough Questionnaire, St. George's Respiratory Questionnaire, or the COPD Assessment Test. You can see the bars there. 62% of people said the CAT score, and I would completely agree with that. Most of these others are not amenable to easy use in the office. The CAT score has I think 9 different elements, 8 or 9 elements that they get points, maybe 10 or 11 actually, but you get points for each of the components. The patient fills it out themselves on a scale from 0 to 5, and it's quite easy to administer and score. And if someone has a score of greater than 5, that's considered relatively mild impact. 10 or more is moderate, and so forth. So it's an easy one to use. Some of these others are fine for studies, for research and so forth, but not for clinical practice. So not only does the GOLD group have the staging, but also the groups of COPD. So you can see the FE1 staging under the green heading there, but on the right, you see the ABCD scoring. And this is based on the number of exacerbations. Greater than or equal to a year gets you into the C and D categories. And then the MMRC score, if that's 2 or greater, then you would be in B or D, depending on how many exacerbations. This lady has had 2 exacerbations in the past year, and an MMRC score that I would rate as 3. We don't have the results of the CAT here, but if it's 10 or greater, then as I said, there's a moderate impact, and that would bump her up.
Yeah. Nick, I think these are, it's interesting that this also represents, a substantial evolution, certainly over the last 10 to 15 years, and the increasing realization that FEV1 is not the only story, right?
Absolutely.
I think we really have understood that the impact on daily life as well as exacerbations, in some respects, modify risk much greater than just the flat FEV1. And that, I think, has been reflected in the GOLD criteria, which initially started just stages 1 through 4 based on the straight FEV1. And it wasn't that long ago that GOLD was reporting that, as I can recall.
Right. And exacerbations in particular are so important for prognosis too.
No, that's exactly right. And I think that this, our guidelines now reflect that, but I think it's intrinsic. And it wasn't that long ago that all we really looked at to some degree was FEV1. And then that started being modified with the Bodie scale with Bart Shelley in 2006, and then has evolved till now. So.
Right. So we know that there is a differential diagnosis of COPD, and you can see the list here. I'm not going to elaborate much in the interest of time here, but all these things might give you obstructive disease. Sarcoid might be on this list in some patients as well, and there are other things. TB is not something I would consider most patients with COPD unless they had fevers, more constitutional symptoms than the average patient, maybe a little hemoptysis and exposure. If the patient's from China, where TB is endemic, then it's much higher on my list. And these are the PFTs on our patient. And as you can see, there wasn't much of a response to bronchodilators. Pre-FEC was 1.47, post 1.48. She has an FEV1 post bronchodilator, which is only 41% of predicted, so she is stage 3, severe airway obstruction. And then her ratio is 47-48% pre and post, again, consistent with severe airway obstruction. We don't have lung volumes here, but the reduction in FVC is probably related to air trapping, and that leads to an overestimation of the ratio. If the FVC was not limited by the air trapping, the ratio would be considerably lower.
Yeah. And that's this classic pseudo restriction, which is seen in severe air traffic and severe airway obstruction, as well as that brief puff and a long expiratory phase, which could suggest dynamic airway collapse as well, I think, on that flow volume loop, Nick. But again, really someone who's quite ill and quite infirmed with airway, with hyperinflation, air trapping, and obstruction.
and certainly compatible with that MRC rating of 3.
Every bit.
So some other history. Her bicarb is a little high, so one would be concerned about CO2 retention, and she does have a PCO2 of 52. Considering that she likely has OSA and she is obese, she also has what we would consider an obesity hypoventilation syndrome. And this is also commonly referred to as the overlap syndrome with a combination of OSA. She did have a stress test with those coronary calcifications. It was negative. She does have a sleep study. Not surprisingly, her AHI is in the severe range. She has an overnight pulse oximetry. She spends a lot of time with an SpO2 under 88%, no surprise. And then she has an echo. She does not have evidence of significant pulmonary hypertension, although this would certainly be a concern with her obesity, hypoventilation, and other factors, but fortunately that's not one of her comorbidities now. And so I think it's time to think about treatment, and so I'm going to turn it over to Dr. Shills.
Nick, thank you. A great review. And I think that, intrinsic in what you pointed out to us too is were all the different appropriate workups. It's not okay for us just to get a Spiro and call it a day. Really, all the national, international guidelines really charge us as physicians taking care of COPD to also assess the expected comorbidities. And so, you described very nicely OSA questioning and diagnosis, the recognition of the comorbidity of coronary ischemia, hypertension, and so forth. In that, as well as although you didn't mention it, certainly she has a CT scan, which is her first CT scan for lung cancer screening, and so. It's not just enough to get an FEV1, look at diagnosis and walk away, but to follow all of the diagnostic pathways to identify comorbidities, which are so important in these patients as well. So thanks for taking us through that, but I think that's important for our audience too. Along the way. So let's talk a little bit about treatment strategies. And this is someone who has had exacerbations, however, is not in the hospital and is now out and about, quite impaired, as Dr. Hill mentioned. So let's go forward. So again, treatment of COPD really is recognizes a number of factors. And this is a great example of a really confusing slide, but I think it's a great example of how taking account of multiple factors is critical in the management of these patients. So again, it's not surprising that the average patient we see is now older with multiple comorbidities. Nick, it's uncommon that you see a patient with just one problem and it's COPD, right? And when was the last time you saw someone like that?
I can't think of it.
And I think that's really
universal.
It really is. And so I think that's really just the key and all of these impact, as is shown by the interlocking links on the right-hand side of the slide. Cardiovascular disease really is critically important as well. I mean, that's what, again, most patients with COPD don't die of respiratory failure ultimately. They'll die of cardiovascular disease, stroke, and cancer. As the expected comorbidities. So these need to be treated, as does the COPD. And so as you can see on the right-hand side, the comorbidities, which can be very, very relevant, are both organ-based as well as cognitive-based. So we see the muscle wasting, poor nutrition, osteoporosis. Remember that cigarette smoking is a risk factor for osteopenia and osteoporosis. Obesity, metabolic disorders certainly are going to play into the cardiovascular risk. And so identification and recognition that all of these may be there is important, number one. And if we look then at treatment strategies, they need to be parsed and understood to match up against this. So drug treatment is something we'll talk about in treating, but it's important not to lose fact and not to lose track of the critical elements of nutritional counseling, both for low and high weight patients, to look at physical activity and coaching. The role of cardiopulmonary rehab is critical, and we might get back to that a bit. Psychological counseling, both the smoking addiction that's present, as well as the depression, anxiety, which is often associated with smoking and chronic disease, again, especially anxiety when airflow limitation and breathing becomes severely limiting. This is important. Self-management is dead in the center of something, and unfortunately, unless patients take an active role in their management, no single physician, no matter how much they care, can possibly care more or be more involved with care than the patient themselves.
And if I could just comment, I think it's fair to say that if you haven't identified at least several comorbidities in each patient, you aren't looking carefully enough. And it's so important to address those comorbidities. So, it's extremely important in managing these patients.
And Nick, I think that this is also, although we talk about medicines, there's also non-pharmacologic therapy, some of not trivial amounts of which are targeted at all the comorbidities that you mentioned. And so for that reason, I put this slide in to bring forward some of the importance of non-pharmacologic therapy. And so which of the following are true? Does non-pharmacologic therapy improve function but doesn't help you live longer? These are not useful in gold type A or B. Non-pharmacologic therapy may decrease COPD exacerbation readmission rates, or does non-pharmacologic therapy tend to have less impact than drugs? And so I think most of you jumped on the bandwagon, obviously, which came first, I think, Nick, in the Canadian Thoracic Society recommendations, where the necessity to have prompt follow-up and prompt enrollment in cardiopulmonary rehab decreased exacerbation and readmission rates. And so that one is clearly true. Functional status, there's some evidence, at least in non-pharmacologic therapy, in two ways. Certainly oxygen therapy has been shown to improve survival among patients who are hypoxic by the NUT trial. Secondly, then there is some data supporting cardiopulmonary rehab as also improving the survival.
Smoking cessation is another one that
I think that's the biggest one, right? I mean, there's nothing better and more impactful in COPD than smoking cessation, and that's a great one, Nick. I was going to lead with that one, and I just got so wrapped up in rehab. But no, I think that's critical. So it's obvious that these non-pharmacologic interventions are critical, in managing both the direct effects, and everything else. And again, you can always stop smoking. You can always look at rehab. You can always treat comorbidities. And again, nobody believed that you could ignore non-pharmacologic therapy. And so great job, everybody. You're right on the money with all of those. So let's talk about some of the non-pharmacologic therapies very quickly, as Dr. Hill led with smoking cessation. Arguably, if you cannot achieve that, you're going to handicap your efforts everywhere else. Physical therapy and pulmonary rehabilitation. Again, if you don't use it, you lose it. People with cardiac and pulmonary disease tend to self-limit, and that leads to progressive muscle disuse and deconditioning. You can always improve people's functional status where they're at. As Dr. Hill mentioned in Our Lady, with an AHI and a BMI all the same and all about 40, she had substantial hypoventilation, as well as all the markers, and severe obstructive sleep apnea, which also impacts her cardiovascular status. I don't need to remind everybody that Heart failure and heart dysrhythmia is substantially exacerbated by untreated sleep apnea. And so critical. Oxygen therapy, when appropriate, is important. And prevention of disease, which can lead to further loss of lung function, is critical. Influenza, pneumococcal, and now COVID vaccinations are critical in helping patients avoid further lung loss and the kinds of devastating infections which can be fatal. Lastly, good nutrition, and this can be on both ends of the fence, either promoting weight gain in those that are severely cachectic, often with very low lung function and severe obstruction, or weight loss, as Dr. Hill said. Carrying around more weight is increasingly more difficult, especially when lung function is poor. Nick, any other comments on these? I think this is a nice list of a lot of the non-pharmacologic therapy, which is really important.
Yeah, one comment is that non-invasive ventilation is now on the list of things that can improve survival. There was a large study out of Germany, randomized control. They saw a drop in the mortality rate over a year from about 30% down to about 12%. So it was substantial. And that's in patients who are hypercapnic. So they have significant hypercapnia. In this country, it's 52 or greater if you want to put someone on any NIV. And the other comment I would make is that, I've always been a big proponent of pulmonary rehab, not only for COPD, but other chronic pulmonary diseases. And one of the sad sequelae of the pandemic has been a contraction in the number of pulmonary rehab programs. I don't know about Cleveland, but in Boston, it's really hard to find rehab programs that are taking patients.
No, that's been devastating. And again, the critical support for advanced therapies, transplant in general, we do have programs opening up, but it has been devastating and really to the negative of all of our patients. And so no, that's been another. And so now they find themselves at the end of the pandemic with terrible deconditioning, which just exacerbates quality of life and their ability to cope with disease. So again, non-pharmacologic therapy is so important, as all of you identified in the questions, but really critical to remember in the management of these patients. But let's go forward. There's medicines to use and there's medicines to think twice about. Certainly, although there have been large VA studies which suggest that beta blockers may have less an effect on COPD, it's always better if one has the opportunity to use cardioselective beta blockers if needed. There's evidence that statins, ACEs, and ARBs may be beneficial. But let's look at the treatment options, because I think we have both excellent and practical guidelines as well as evidence-based medicine to help guide our decisions. So, our options include monotherapy with the long-acting antimuscarinic agents, monotherapy with LABAs. Nebulizers can help deliver ipratropium and albuterol, and I think we're going to have some discussions about respiratory flow and so forth. The addition of inhaled corticosteroids, both with additional and 3 drugs are all agents. So I'd like to take you through these and see if we can make some sense of those. It's, again, I would refer you, as Dr. Hill did, to the GOLD guidelines, the Global Initiative for Obstructive Lung Disease. I find this a really excellent guide which brings together evidence-based medicine as well as practical guidelines for the management of patients. And I think this is very, very useful. So if we look at going from left to right, increasing severity of patient disease, we have the group A patients. They tend to have better FEV1s, although not exclusively, low impacts with regard to the dyspnea with activities, and as Dr. Hill reviewed before, the CAT score of less than 10. And these patients may simply be treated with a bronchodilator, and this can be even a short-acting as-needed bronchodilator. However, at any stage, the patient's response to medication and their symptoms need to continue to prompt reevaluation of the therapy and the adequacy of therapy. And I think that's important no matter where you are. You need to tailor the therapy to patient profile and patient response. If we move then up, long-acting agents tend to be more useful, with the combination really being preferred over single agents in a number of the guidelines and a number of the evidence-based medicines, especially among patients with dyspnea and exercise intolerance, as noted in the ATS guidelines seen at the far right of everything. But let's talk about dual versus monotherapy bronchodilation. And we have certainly the benefits of early utilization of the dual therapy, according to ATS recommendations, are improvement in lung function, improvement in symptoms, and lastly, improvement and reduction in exacerbations. And as we noted earlier, that reduction in exacerbations increasingly is both used as an endpoint in a number of trials, as well as recognizing as a critical piece of, management of COPD in the modern era. So let's take a look then at the current ARS. Which of the following is true about the addition of an inhaled corticosteroid? And the answer then is,
I can see them well.
So, yep, and that's exactly right. Obviously, pneumonia, if anything, and this has been the debate, right, Nick, from the very start,
right,
when we first started seeing the data and meta-analyses continued to confirm that, as well as large, well-constructed trials showed that we were able to clearly decrease exacerbations, but perhaps at the expense of some pneumonias, which in defense usually were non-fatal overall, but nonetheless, these are issues. There is some data that suggests that mycobacterial infections may be exacerbated by the use of steroids, and obviously emphysema is just COPD, and that's part of what we need to treat, along the way. So, but certainly when those things occur, certainly for the purpose of exacerbation, that's important. So we now have triple bronchodilator therapy. Certainly by the time patients are not responding, they continue to experience exacerbations, and that might be maybe number one. Have poor quality of life related symptoms, have higher number of eosinophils, and then continue to be symptomatic. There's a lot rolled into this slide. And so I think I just want to go a little bit on that, although I know that time is marching on. Certainly we mentioned exacerbations have clearly been associated and can clearly be reduced by the addition of inhaled corticosteroids. The circulating eosinophils, Nick, we've sort of dropped the concept of the combination or overlap syndrome with regard to COPD and asthma, but certainly recognize that a number of people have asthma-like components to their COPD and certainly have a lot of fixed obstruction. And so I think burying this in there recognizes that. When do you usually add inhaled corticosteroids to your regimens for chronic stable COPD patients?
Well, if they're chronic stable, meaning they haven't had exacerbations, say in the previous year, I generally don't use them as a routine. I will use dual, LABA/LAMA, but if someone is starting to have more exacerbations, if they're wheezing when they come in and their symptoms are not well controlled on the LAMA/LAMA, as it suggests here, those are the main reasons I would pull one out of my pocket. I think the data is reasonably convincing that in the Group D patients who are having continuing symptoms, you can get benefit over dual combinations alone, but it's for a selected group of patients.
Yeah, so I think that really you're really looking at those groups with exacerbations predominantly more severe symptoms and lack of total response to symptom control on the LABA/LAMA. And as Dr. Hill pointed out, not surprisingly, the evidence tells us we have strong support by decreasing hospitalizations and exacerbations, mostly in the sickest patients with a number of exacerbations and people with concomitant asthma. Certainly, anything less than that is certainly possible. And again, if patients have repeated pneumonias, at least you have to think twice. Certainly, they've been prescribed, but those are issues if people don't have asthma components. And lastly, this mycobacterial kind of thing, which does occur, at least in our neck of the woods, we have fair bits of non-tuberculous mycobacteria with co-infections and co-colonizations in our patients. So a relatively newer concept, and Nick, I think this came into the GOLD criteria 1 or 2 ago for the first time, based on studies which show that in some degree, in a parallel to asthma, just because you escalate therapy up doesn't mean you can't drop it down. And so I think that this is a small, somewhat complicated kind of rubric, but we know we do have some data which suggests that on certain combinations and in certain patients that de-escalation is possible without increasing exacerbations or decreasing control. So at least I think this slide is an advertisement for at least considering and becoming more familiar with the concept of de-escalation in COPD. It is in the guidelines, and I think it's important to at least understand that not everybody and not all pharmacologic therapy is a one-way street. And I think that's especially with regard to the inhaled corticosteroid, that can be stepped down occasionally on some people under some conditions with maintained control. And without going further, I think that the main thrust of this slide is at least being familiar with the fact that there can be de-escalation, as well as escalation based on exacerbations and lack of control primarily. So in treatment then, if we look at our lady, she was prescribed a dry powder, but says it's hard to use this and I don't like it with my breathing. She also says that even after she uses her inhaler, she doesn't feel well. She's using rescue a lot, which concerns the patient. But implies that the rescue agent actually feels better. And so when these kinds of things come up, that makes me suspicious maybe about her delivery system and her ability to use things. And I know, Nick, we talked about this before, but certainly poor inhaler technique is one problem. We have a number of patients with manual dexterity or other kinds of things that make it tough to both actuate and synchronize the breath, exhalation, and inhalation. Lastly, it's important to know that we often don't consider the device that we prescribe. And we know that it can be relevant, especially in people with limited inspiratory flow, that inhaler selection can tremendously impact drug delivery. And in point of fact, dry powders in specific tend to require higher inspiratory flows to be able to deposit effectively and to be able to extract the powder from the device. And so especially when you prescribe dry powders, as this lady had, you need to remember that patients that are poor in developing inspiratory flows may not get the same kind of benefit from these kinds of devices. And considerations of other chambers that might be micronebulizers or even nebulized therapy may be important. As noted down here, about 20% of patients with advanced COPD have impaired inspiratory flows, and these may substantially change how we think about and what we prescribe for inhaler-based regimens. So this patient then was changed over, realizing and feeling that inspiratory flow was a problem. She is now using a nebulized long-acting antimuscarinic and a nebulized long-acting beta agonist. And lo and behold, things got better. And so I think that this is an important kind of reevaluation. So this is a very, very long list of our choices. And I think, Nick, I'm going to see how you think about your choices, but I like to have choices in each of the categories, the consideration of choices that may be nebulized or not, and as well as those that may be delivered by dry powder versus other cloud chambers, and as well as the convenience of once or twice daily administration. And so I like to be able to pick things that fit, especially inhalers in those categories, but realizing that we also have ancillary drugs that can be used in the appropriate places, such as mucolytics, roflumilast, which is a phosphodiesterase E4 type inhibitor, and an anti-inflammatory agent to decrease exacerbations. But at least I like to make sure that I have targets that can target and tailor to patients that may have poor inspiratory flow, may need long-acting agents, may need nebulized agents. Again, making kind of a concept of, when do I use having mucolytics to use and other ancillary agents. Do you have any kind of a quick recipe of how you make sense of a chart like this?
Well, nothing too quick, I would say, but it's certainly nice to have a lot of choices, especially with the LABAs. We can get dry powder, we can get nebulized, we can have rapid onset, like with formoterol, or slower with salbutamol. And one thing that always amazes me is how far we've come. I finished my fellowship in 1982. They were just coming out with inhaled beclomethasone, which was garbage, and the patients would come back and throw those things at me. But it turns out that we were always underdosing them because you had to take so many puffs in a day. When I did my internship, we used to use isoprel a lot, isoproterenol, which had a duration of about 1 hour. And now with one puff once a day with some of these agents, we can get the equivalent of what would have been about 40 puffs back then. And that's why they're so much more effective, because they pack so much power into a single puff. I certainly don't use devices like that on everybody. I notice they include theophylline once a day. I don't know anybody who's using that anymore. I don't even know if you can get it, but I guess they wanted to have a complete list.
No, I remember when that used to be the only thing that used to get some people through the night.
Well, that's true.
None of these other agents, and I think that historically that's relevant. And certainly in non-Westernized countries, there still is, oral, theophylline, which is still available worldwide. And so I think that's included here for sake of completeness. But as you point out, we don't see that much anymore. And again, I think it's a tribute, as you point out, to the incredible power and the incredible convenience of these inhaled agents, which have really revolutionized our ability to deliver powerful and convenient drugs in an inhaled fashion to our patients. So, in looking at then follow-up's important. And actually, for the first time, those kinds of guidelines are also existing. In the past few years, recommended follow-ups with regard to how long after either an acute exacerbation or on regular follow-up, and what elements of follow-up ought to be looked at during those follow-ups are now prescribed in a number of the guidelines. And I find this really, really useful. And now that we have electronic medical records everywhere and the ability to either do templated follow-ups, or word expanding templates, there's no reason not to build in all of these elements into follow-up. And I do that for my COPD patients, which makes it really, really easily. So I think review, we need to review patient symptoms, dyspnea, exacerbations, therapies, ability to comply with therapies, as well as their dexterity, ability to generate inspiratory flow, and then assess, are we doing all we can do for our patients? do the individual agents that we have picked with regard to pharmacologic therapy fit the profile of our patients? Do they have asthma-like symptoms? And should we consider inhaled corticosteroids? Do they have dexterity problems that would benefit from a nebulized treatment? Are we maximizing our non-pharmacologic therapy? And I think from my standpoint, I think the two elements of non-pharmacologic therapy that I probably see underprescribed are cardiopulmonary rehab, both close to my and your heart, Nick, and oxygen therapy. It's amazing how many patients show up on my doorstep, at least, that deserve both of those that have neither. And I don't know if that's your experience as well in the Boston area, but,
We certainly see that.
That goes without saying. And lastly, adjust. These medicines are not a one-way street. The ability to respond to inadequacy of therapy, exacerbations, or the recognition of prolonged stability and the possibility of de-escalation of therapy is critical, in all of these patients. So I think to review, to assess, and adjust is part of every patient follow-up. And to borrow from Dr. Hill's initial discussion, the need to assess and reassess and identify comorbidities are critical. And so I think that it is important then to take into these account when you bring patients in, make sure that all the boxes are checked. And I find it very useful to template my follow-ups for COPD patients, which walk through all of these elements of comorbidities, assessment, reassessment, and adjustment, which are dictated by now our national and international guidelines. So in conclusion, we know the WHO predicts that within 10 years, we will become the third leading cause of death behind heart disease and cancer. Symptoms can lead to a meaningful decline of life, status and prognosis, and early diagnosis is important to reduce burden. Both over and underdiagnosis are often reported. And we didn't talk about overdiagnosis, but, patients missing a diagnosis just because someone's smoking doesn't mean that their dyspnea is automatically ascribed to COPD. And again, spirometry tells you whether or not you have the O. Let's always remember to confirm the diagnosis of COPD with spirometry, identify the comorbidities, and look at optimal aggressive therapy using both pharmacologic and non-pharmacologic therapies targeted at specific COPD, tailored to the patient, but also looking at and identifying and treating comorbidities, which are expected and common in this disease state. And so I think with that, I would like to close. Nick, closing comments to you before we go to the questions, because I think we see a number of questions on chat, and I'll ask our moderators to kind of walk us through those.
I think you've done a masterful job of summing it up, so nothing to add.
All right, Nick. So it looks like we have a few things here. My first one I can see is what COPD triggers should we advise patients to watch out for? And what other COPD-related complications and health conditions do you advise patients to look out for? So by COPD triggers, I don't know if that is, things that either are risk factors for COPD or triggers for exacerbations. I'm not sure of which of those are. Certainly, infections are common triggers for COPD exacerbations. And so appropriate protection, appropriate immunization, and so forth are critical, to avoid those kinds of things. Patients with asthma-like triggers, inhaled aeroallergens, exposures, smoke, and so forth can be triggers as well. Nick, anything that you can think of to crack that triggers question?
Well, other environmental triggers like during the summer, poor levels of, unhealthy air, hot, humid. We've just gotten through a very hot summer, and a lot of our patients were having difficulty getting exposed to cigarette smoke. Sometimes we'll do it. some people are sensitive to paint. A lot of the triggers are environmental, and you've mentioned the infectious ones.
Yeah. And so then other COPD-related complications and health conditions, what do you advise patients to look out for? I think Nick, you covered, a lot of the comorbidities and went all the way from psychological burdens of the disease, cardiovascular disease. It's important to remember that smoking is also a potent risk for cancer of all types, going beyond, but also a risk for kidney, GI, and breast cancer, as well as lung cancer. So I always note that, and that's often a very eye-opening thing for appropriate populations that realize that, hey, oh, by the way, I can get other kinds of cancer from this too. I don't know if you have other kind of health-related conditions that you can advise. Certainly, oral health can be, impacted by tobacco use as well, and as well as head and neck cancer. Going down the list, the next question is, can phenotyping help identify which patients could benefit from personalized therapy? We gave a few examples of those. Nick, you identified the use of non-invasive therapy among patients with hypercarbonic respiratory failure, as being very useful. We identified an asthma-like phenotype with high prevalence of eosinophils as being a possible phenotype that may benefit or may be considered for inhaled corticosteroids. Those are a couple that I can think of right off the top of my head. Certainly the obese patient, as you mentioned, optimal nutrition and so forth, is important, and focus on obstructive sleep apnea. Any more phenotypes that you routinely recognize, assess, and personalize?
Yeah, well, I think the gold ABCD grouping is a form of phenotyping. You're looking for the frequent exacerbator as opposed to the non-exacerbator, people who are very distic as opposed to not, and those are helpful in tailoring treatment. So, I think it starts there. I think you've pointed out some good additional types of phenotypes that might warrant some additional or different approach.
Super. Our penultimate question then is, when considering a maintenance medication for a newly diagnosed patient, is it more important to consider the medication class or the device type? Well, I think that the nice part about it is that we can deliver essentially any class by a variety of ways. And so if I were going to vote, I would certainly start voting by the medication type, but realizing that how you deliver it can carry equal importance especially among patients with limited inspiratory flows. Nick, your thought about that?
Yeah, I agree. I don't think you can ignore either of these things, but the guidelines with regard to therapy don't really consider the device very much. It's more, medication directed. But we pointed out how important it is, if you are using a dry powder inhaler, to make sure the patient has adequate inhalational flow to trigger or deliver the dry powder, and so that's an important consideration.
So I think, as you pointed out, the incredible development of drugs these days now make almost all agents available to us in a variety of different ways of delivery, so that we rarely have to, I can't even think about having to discard any type of drug because I don't have a way to deliver it that I think is appropriate for the patient. And I think that's really great, great options. Lastly, we have Dr. Farber, who is asking about the development of pulmonary hypertension among patients that may lead to worsening control in COPD, and asked when do we think of it, and then how do we think about diagnosis and treatment of that in this relatively less common group among patients with COPD.
Well, pH is certainly an important comorbidity in people with COPD, and if they have pH, their prognosis is poorer. the times I would think of it would be anybody who has manifestations consistent with right heart overload or failure. Our CT scans can be helpful sometimes because they can show a main PA trunk that is larger than the aorta.
I was just going to bring that up. It's also the CT scans are the poor man's echo, right, Nick?
You got it. And then patients who seem to have disproportionate dyspnea, considering the severity of their COPD by PFTs and comorbidities and so forth.
Well, Nick, the hour is late. I'd like to thank you. It's great to reconnect, and I'd like to thank all of our audience as well as our sponsors for inviting Dr. Hill and I to share with you some of our perspectives and a review of initial considerations of the factors surrounding diagnosis and management of COPD. Nick?
Thank you, everybody. Thank you, Bob. This has been fun.
Good night, all. Be safe.